Good morning. We're going to give just a few seconds for people to get in here, and then we will get started. Okay, we're going to go ahead and get started. Good morning and welcome to the opening session of our 2025 Recovery Summit. This annual webinar series is proudly hosted by St. Clair County Community Mental Health each September in recognition of National Recovery Month, a time to celebrate recovery, raise awareness, and highlight the importance of support and connection. A quick reminder, today's session is being recorded and will be available on the St. Clair County Community Mental Health YouTube channel. Please use the chat box for any questions or comments. Our presenters will address them as time allows. For those requesting continuing education credits, please be sure to remain on the webinar for the full session and complete the survey that will be sent to you to your email. To begin our summit, it's my pleasure to introduce Deb Johnson, Chief Executive Officer of St. Clair County Community Mental Health, who will officially kick off this year's event. Welcome, Deb.
Thank you, Christy. So I am excited to be here today to kick off the, she probably said it's probably our sixth recovery summit. We started during COVID when we were forced into this format, but it turned out the format was pretty good. So we decided to stick with it. So today I am joined by Sherry Jessup. She's a supervisor at St. Clair County Community Mental Health. And Jen Ritchie, another supervisor. She's with IDDT. Sherry's with the SUD group. And but I'm going to start first, and I want to talk just a little bit about St. Clair County Community Mental Health in general. So first of all, we provide. Oops, sorry, I forgot I'm the clicker too. There we go. So St. Clair County Community Mental Health provides services and supports to adults with mental illness, children with severe emotional disturbances, adults with intellectual and developmental disabilities, and adults and children with substance use disorders. Our services are person-centered or family-centered. They're very trauma-informed, recovery-oriented, and our focus is on integrated healthcare. We have locations throughout St. Clair County. We actually have we have an office out in K-Pac. We call it CMH West. We have our children's building in Port Huron on 24th. Our main largest location is in Port Huron, 3111 Electric Avenue. And then we have two locations in Marine City. One is in downtown St. Clair on Broadway, and the other one is on King Road. So we're all through the county. Oh, click. What's going on here? No, it's not clicking. There we go. Sorry, it was stuck. Anyways, the services that people receive are tailored to their unique needs and goals. We utilize evidence-based practices or promising practices. And Sherry, I think, is going to talk more about those specifically. Yeah. So that's all I'm going to say for now about that. Sorry. Our access, I want to talk a little bit about access to services. It's changed a little bit, as some of you know, over the last couple of years when we became a CCBHC, which is a certified community behavioral health clinic. So we currently serve just about anybody, people with mild to moderate mental health conditions. Of course, we still serve the most severe populations in accordance with the mental health code. But it's pretty easy to access our care. You can call our access center. You can call 24/7, but if you're not in crisis, they're going to have somebody call you back the next day. Currently, the number is 888-225-4447. That number will continue to work after October 1st. And although it's not on your screen, I just want to give you a heads up, advance notice that effective October 1st, we're going to have a more direct access number, which will be directly to St. Clair County CMH. And that number is going to be 810-488-8888. So all you have to remember is the 4 and all those 8s, and then the phone will start ringing, and you know you have the right number. At any rate, basically, the process is that we do a screening, and then our new process will be, we'll set you up quicker for, we hope quicker, for a full intake, and then we'll go from there. And so if for some reason somebody doesn't qualify for our services, we'll make our referral out into the community to help folks out. The other number I want to talk about that's really very important is our rapid crisis response or mobile crisis unit, which is, they can be contacted or accessed 24/7 by calling 810-966-2575. And a human being answers the phone 24/7. So I always say to people, even if you're not 100% sure, is this a crisis I should call somebody in the middle of the night? Do it. If you're hesitant, you're even thinking it might be a crisis, call, because you can talk to our trained staff and they can help kind of guide you through whatever's going on, or they'll come out to see you and do an assessment themselves, help you to de-escalate the situation, and decide what kind of intervention is most appropriate for the person. So please don't hesitate to call that number if you need to. Okay, now.
Okay.
Yeah, now I'm turning it over to Sherry. She's gonna go first, and they're gonna go back and forth about the more specific services.
Okay. All right, here at CMH, we offer substance use disorder services. Just for some clarity, I am the supervisor of the SUD department, which has morphed over the years. It developed as we became a CCBHC. So I'm not going to just stick to SUD because we do see people with substance use disorders only, but the majority of people have co-occurring mental health and substance use disorders. So I sort of want to include that. Just because even my staff for my department, we see people for both the SUD department and for the outpatient department. Individuals with mental health or substance use are more likely to have experienced trauma. This is really significant because we get people in the doors, they have a co-occurring substance use and mental health disorder. And a lot of times there is trauma. There can be trauma for somebody with a mental health disorder or trauma with somebody with substance use disorder, maybe lifestyle, maybe it happened before. People with a mental health diagnosis are more likely to misuse substances. A lot of times this starts out as a coping skill and just sort of progresses toward there. Maybe starting doing things with friends, and then just things get bigger and bigger until there are a lot of problems. Individuals are less likely to seek medical services. So what we see a lot of times is people coming into services, they need help with their mental health, they need help trying to figure out a way to be in recovery from substance use disorder, but they haven't had medical care in quite a while. So that can be significant. And as an agency, we try to link people with the services they need in the community. And one thing I like people to remember is there are multiple pathways to recovery. So one person's recovery may not look exactly like another person's recovery, right? So that's something that is also individualized through services. We figure out, we may talk about what they would benefit from, but the person chooses what is important to them and what they want to work on. Yeah, any comments about that? Stigma continues to play a role in engagement. So I believe that over the years with CMH, there's been a lot of stuff out there. We have really been addressing and done a great job addressing mental health stigma. A lot of people didn't want to be viewed as somebody with a mental health diagnosis, and we've been more out in the open about that. It does continue to play a role, but we are very engaging in the community about that. What we need to think about is that stigma continues to play a significant role when it comes to a substance use disorder. So sometimes people don't want to step out. They don't want to admit that there's a problem or that they're losing control. And sometimes that can stop people from seeking the services that they need because they're judging themselves and they don't want other people to judge them. Anything to say on the stigma piece?
No, I completely agree. Stigma still plays a significant role.
Okay. So CMH We do a lot of training with our staff. Our staff goes through a lot of training, not in every single thing, but a lot of times we end up sort of specializing in it. So we have 24 evidence-based practices that we use. And what an evidence-based practice is there has been a lot of there have been studies on all of these approaches. And they're looking at it with certain disorders, with certain age groups. And the evidence is showing in this research that these are very effective on certain things. So I was thinking that Jen could help me because motivational interviewing is a big part of what we do. And it's sort of an approach. So most of our staff who do direct services are trained to a certain degree in motivational interviewing. So it's how do we engage a person, and get that and develop that relationship. You do a lot.
We do. In our department, motivational interviewing is something that everyone is extensively trained in and we use daily. And so the goal really is that you're going to find out what's important to the individual that you're working with, where they're at in making a change. And so we're really just spending time in ambivalence with them. We're listening to the cost and the benefits of their substance use and acknowledging both and acknowledging them as the expert in their life. And a lot of times in just being able to stay in ambivalence with the person and capitalize on that change talk, they start to build desire and belief that they can make a change.
Thank you. So another big one, especially when it comes to substance use disorders, is medication assisted treatment. So we have psychiatric providers on staff who become part of our treatment plan and part of the team. And people have always come here for medication for psychiatric disorders. But we have our providers are also trained in different medications that assist people who are new in recovery, or if it's for long-term recovery from substance use disorders. So there are a lot of medications out there who will help people with cravings from alcohol, from opioids, and it just gives them more of an opportunity for success in a long-term recovery. That is something that people would talk about. They would talk about wanting help from a psychiatrist or a nurse practitioner, and their case manager would get them linked with them. And our nursing staff is incredible here. They even meet with the people. And so a lot of these medications can be either oral or there are some that are injection. Anything you want to say about that?
I think that, yes, our programs to help somebody have an extra, I want to say, support in their recovery, that our prescribers get great psychoeducation about it. Our nurses are very supportive, and we have groups and therapy that come alongside to help aid in recovery. So,
Okay. We have others too, such as we have multiple different trauma treatments. People are trained in the different things. We have prolonged exposure therapy. We have eye movement desensitization and reprocessing treatment. Those are focused right on trauma. And a lot of times if people can stop their reactions, from their reactions when they're triggered, this can help lead to long-term recovery also. Another thing is dialectical behavioral therapy, which is evidence-based for borderline personality disorder. The majority of people that meet the criteria also have traumatic pasts. So we offer DVT, prolonged exposure therapy, which can take place while they're going through the year-long program of dialectical behavioral therapy. So again, these are great ways to help the recovery, help you hit a new level, and this is for long-term. We also offer groups, so we have trauma groups for women, which is based on that. Okay. And then we have seeking safety, which a lot of times is just women or just men. And it helps people who have some reactions to their trauma and it helps ground them. We're having some difficulties with our screen and what we're seeing, so I'm getting notes passed to me.
Tell them we're gonna take a 1 minute tech break.
We're gonna take a 1 minute tech break.
So everybody has to drink their
I was
coffee.
I was trying to write neater. Mute it. Christine, mute it.
We're still working on our issue, so just give us a few more minutes. But while we're waiting, I just thought I would let everyone know, this is just the first session of our recovery summit. There are, at least 18 more sessions. And, if you're interested in any of those, you can go to our website. It's www.sccmh.org. And then you click on the events tab, and right under that tab, there is a recovery summit, and it shows all of the different sessions. It gives a little description and tells you what credits that session will be, is eligible for. Just a little reminder. Also, there will be a survey that's sent out to all of you after this. Please take a few minutes and complete that. I think we should be coming back on just a minute here, so just hang tight, and we apologize for this.
Where's in a chair or something? Silence is golden.
We're all set? Okay. Christie,
Can you hear us, Christy?
says the microphone's muted or is it coming? from
Yep,
Dee?
we can hear you.
So sorry about that. I think we're all back. Nothing's moving around. It should be, so, sorry about that. We were talking about the evidence-based practices, right? And I won't be able to get into every single one. So we have, depending on symptoms and what people want, we have these different things that we offer that maybe that people can take. One plug I wanted to put in here though was for mental health first aid. That's not something that you get as a result of services. That is something that we as an agency offer. We have staff that are trained in it. I know it's something that I used to do and I used to love doing it because if you have a community group who has enough people together, you can contact us. We will come to you. You could either come here, we offer these trainings in-house, but we've also gone out in the community, done it at churches, at
I think we
DHS.
just need 15 or more.
Yes. And it's free to anybody in the public. And we have mental health first aid geared at adults who are having a problem. And we also have it, people trained in ones for children who are having a problem, how to help somebody in the community. And I believe that just after doing it this amount of time, we even teach people how to talk to people, how to stand, who to call for help. And there's a different section too with substance use disorders. If you come across somebody who's overdosing, And just the book itself that they give out for this training, I think it's worth it right there just to spend that. So it's either an all-day training or it can be 2 half-days. I recommend you look on our website. We usually promote when we're going to have them, right? Or if you have an organization that wants all of your staff trained, just call us and we could figure out something so we could come out and train your staff. Any that you want to cover for sure?
No, I'm gonna get into some, like IDDT here in a minute.
Okay. And before we go on with that, we had skipped over one slide just because we knew that we were going to be talking about quite a few things. When we talked about there being multiple pathways to recovery, I don't think I can go
Let's
back.
go back to.
All right, so in the multiple pathways, what happens is somebody comes in for services, they do an intake. And based on the intake, it's recommended that they get, maybe case management, maybe clinical services. Once they start meeting with whoever their primary worker is going to be, they start talking about symptoms and then what services do we offer. Through that, that's what we call person-centered treatment, is the person is picking out with their worker what they're going to go for. So they might say, I want to see a psychiatrist, or let's say they're homeless and they need some help. So not that we provide housing, but we have case managers who will help them in the community with finding out where there's openings, putting in paperwork and everything for that. So another thing might be the person's been unemployed and couldn't find something. We have an employment program where we sort of get that all going, and that's where that's person-centered. And another thing might be they have health conditions that they haven't sought treatment for. So we may help them find a doctor in the community and get them linked with that. And we also offer a lot of groups and classes and such. So I just want to make sure I put that in there. And
maybe one thing we want to cover with that as well is obviously people have to meet specific criteria for certain services, especially psychiatric, and things like that. And the other thing that people have to remember is that depending on your insurance type, and that's been kind of a big source of confusion maybe for some people or misunderstanding, because now that we take private insurances, they don't pay for all the services we provide, unfortunately, but mostly Medicaid does. And so, so those are all important things to discuss upon entry into our services with your, especially as soon as after your intake, as they're talking about your treatment plan. That's an important topic. So
right, because we're learning that too. We're finding out things that may not be covered. And depending on symptoms, we may have to look into some other options too. Okay.
Okay. So my name is Jennifer Ritchie and I am the supervisor of IDDT. And so I'm going to talk about what that is and how we provide our services. So IDDT stands for Integrated Dual Disorder Treatment. Dual disorder, or you sometimes hear co-occurring, is when somebody is struggling with both mental health and substance use challenges in their life. And so when they come to us, we are providing integrated treatment, meaning that you don't need to go to one prescriber and they're going to help with mental health, and then you go to another agency who is going to help with substance use. We are treating the individual, their symptoms, and their unique circumstances. And so outpatient is like that as well. They provide integrated treatment for dual disorders. So what makes our department different is when individuals come in and they go through some of the services and outpatient, say they have a clinician, they have a case manager, they have a peer, and these things are not effective. They're still having frequent hospitalizations, maybe frequent police contact or incarcerations because their symptomology is causing significant distress in their lives. And we find that outpatient services are not intensive enough. They will come to our department where we have a multidisciplinary team. Our team is made up of clinicians, case managers, peers. We have a nurse that works in the community, and we have a prescriber. And so all of us are working together. We're collaborating together to help meet the individual's
needs and circumstances to hopefully help reduce that higher level of treatment that they're utilizing right now by having a lot of trips to the hospital. And that similarly is sometimes people aren't seeking out medical care. They don't have a primary care provider. We may start there. We may start getting them into the doctor regularly. So hopefully they don't have to go to the ER to have treatment as frequently. And so we collaborate together, we work together to figure out what interventions are going to be most helpful for that person. And our services are provided, 80% of them are provided in the community. So our nurse goes out into the community, our case managers, our clinicians, to meet the person where they're at and walk alongside them to work on the things that they find important to them. So see if I can make the switch. Okay, so the primary goals of IDDT, often people come to us, they have lost their housing. Again, they may have frequent police or court interaction. They have frequent hospitalizations. They've a lot of times lost a lot of their natural supports and may not have any type of income. So those are the things that we want to address to help them start feeling like they can have hope in building a life that they feel is worth living. So one of the benefits of having this integrated team is that they're going to get frequent and consistent appointments that are going to work on housing applications, that are going to go alongside them to the doctors and advocate, go alongside them to the landlords and advocate with them, and build skills for them to start doing those things themselves. We try to increase as much community supports as we can. We are often linking them to Harbor Impact, the Food Depot, BW Rock, walk alongside them to go to meetings and help them build comfort in going to recovery meetings. If that's something they find important, we'll link them with benefits coaching or employment specialist if that is important to them. And then lastly, this is how I wanted to talk a little bit about how we determine our how we provide treatment. And so we use the trans theoretical frame. And so what we do is we look at what stage of change they're in, and then we match the stage of treatment to that. So if somebody is pre-contemplative, there's no problem, I don't have a problem, then we're working in the engagement stage. We're meeting basic needs, we're finding out what's important to them and going to do those things with them. Maybe it's going to the soup kitchen with them. Maybe it's taking them to Clubhouse because they just want to have some socialization, or to the Port of Hopes because they want to have socialization. With that, we're building a therapeutic alliance. So that way, hopefully they become a little more trusting, and we're going to move into, okay, this is a problem in my life, but I don't know that I really want to change it. And that's where we can really utilize that motivational interviewing and talk about the costs and benefits of making the change or not making the change. Once we get into the action, that's where they now have built up enough belief that they can make this change and they want to work at it. And this is where we're going to put in evidence-based practices such as cognitive behavioral therapy, prolonged exposure, cognitive processing therapy. We're going to work with them to build skills and a relapse prevention plan, solidify medications that they feel like are helpful, help them learn how to advocate when they're at the prescriber's appointments or at their PCP appointments. And then lastly, once they have gotten into a sustained place of feeling like they are in recovery, this is what their recovery looks like, we're really going to build up the community supports, build up the relationships that they find important to them, help them walk through those things so they don't need us anymore. And so that is a little bit about IDDT.
Okay. You want to switch or you want to stay where you're at?
I'm gonna see where I'm at.
I have just a few questions for you, Jen. Let me see. Is IDDT T only for adults?
DDT is for 18 and older.
And this might be for maybe Deb, I don't know. When the access number changes, what happens if they call the old number?
It's a great question. It will roll over to our number, or there'll be a warm transfer. It won't be an automatic rollover. There'll be a transfer because that 888 number will still be hosted, I guess, by Region 10. And for straight substance use, access to substance use disorder treatment, you still will have to call the 888. But for the mental health, you call the other number. It is a little confusing, which is why both, if you call, hopefully we'll have the no wrong door practice going on here. You'll call either one of them, and if you needed to call the other one, we're going to transfer you over. So hopefully that will work smoothly.
Okay, thank you.
So we wanted to just spend a little time talking about the relationship, I guess, between suicide and substance use disorders, because we know that people who have a substance use disorder are 6 to 10 times more likely to die by suicide. Currently, 22% of suicide deaths involve alcohol intoxication at the time of death. And around 90% of the people who die by suicide have a diagnosis of both mental health or substance use disorder. Also, substance intoxication is present in about 90% of the suicides that happen with a gun, a firearm. And in the first 1 to 2 weeks after detox or discharge from a treatment center is typically the period of highest suicide risk. I assume you guys would attest to that because they're in the treatment world. And so that's when we want to make sure we really do pile on supports for people and provide what they need, make sure they have plans in place and things like that. And also adolescents who use drugs or alcohol before the age of 15 are 3 to 4 times more likely to attempt suicide later in life. So that's really important too, because if any of you have seen the MiFi data, which is the data that the health department kind of conducts a survey every 3 years, I think. But anyways, it's showing that kids younger and younger are trying drugs and alcohol. And it's so important that we continue to educate kids about the dangers of using drugs and alcohol. And again, about 25% of adolescents, again, with substance use disorder reported a past year attempted suicide, compared to only 4% for adolescents who don't have a substance use disorder. So you can see that's a significant increase. So it's really important, and we want to make sure that that people understand the facts out there. You share the facts, educate kids. Education is probably one of the biggest keys to prevention. And so again, we're pretty much done. I want to talk a little bit about 2 events though.
Can I just say a couple
Yes,
things
you
to that?
may.
It's, intoxication is present in about 40% of the suicides by firearm, which is interesting because firearm is significantly more a male. They tend to attempt by firearm most often, but with the intoxication, a lot of times what happens is we lose inhibition. So it might be something that has been on somebody's mind or they're really frustrated. It's once you're intoxicated that it starts sounding like it's okay and you're more likely to take that next step where you do it. Another thing about detoxing and discharge is in those first 1 to 2 weeks after, accidental overdose is also really significant because of people go out and use what they used before they detoxed and maybe much rehab and stuff like that. So yeah, both of those are really high. I just want
I thought about that because I know for sure a situation like that. And that's important that people don't think about that. You think because you can handle, I don't know, however much I had it before you detoxed, you can drink that much again or use and you can't.
right.
So yeah, so that's more accidental. So those are important things. And we just want to wanted to raise your awareness about that as well. Because there's a couple things happening in the next 30 days, 30 plus. But the first thing that's happening is the Recovery Fest. Blue Water Recovery Outreach Center spot is the organizers, the main organizers. They put on Recovery Fest every year. That is on September 13th. It's Saturday. It kicks off with the Strides for Recovery 5K run walk. And this year it's going to be earlier. I did talk to Patrick and I said, nobody wants to run at 4 o'clock in the afternoon. So get that done. So I'll be there and I hope other people will join me. It's in the morning. For specific information, you can go to our website or Facebook. Also, B-Rock has their own Facebook site as well. And there's advertisements all over the community. And we are a sponsor, a partner sponsor, I guess, with them. And so we want to help promote it. The other one is the Walk to Remember, which is the suicide prevention awareness walk that happens every year. That happens at East China Park. Oh, I should have said Recovery Fest is Pine Grove Park. But the other walk is East China Park, and it's Sunday, October 12th. And again, you can get information to register for that on our website, our Facebook. There's also through the community service coordinating body. Both events will be being promoted, and it's just both of those are really great events, and so we hope that you will check them out. So that's it. Other than that, I just want to remind you again, like and follow our Facebook page for all kinds of information, not just the couple things I just talked about. And also we have a LinkedIn page for our job postings and things like that. We hope you'll follow us, our YouTube channel for video content about mental health and wellness. And actually, all of these webinars will be on our YouTube site, although you don't get CEUs for watching, that you have to be here live for that. And any other questions, I guess, give any of us a call. And anytime, give us a call if you need any supports, resources. If you want somebody to come out and talk to your organization about what community mental health provides, let us know that as well. And so before I thank the co-presenters here, are there any additional questions, Christy?
We did have one question about how would someone get a loved one? How would someone get their loved one into IDDT if the person is not ready for SUD services?
And so if somebody is willing to come in and have services and they meet the criteria for our department, you don't have to be ready to make any changes to come to IDDT. You don't have to say, I want to stop using substances to come to IDDT. And the other thing I want to say is our services aren't time limited in IDDT, meaning if somebody's in a stage of change that's pre-contemplative or contemplative, we don't say, well, you've been here 6 months and haven't gotten better. No, our goal is to continue to work on the things that are important to the person to help them build a safe and fulfilling life and work on harm reduction and get them needed services. So I would say if your loved one is in CMH, to have their case manager put in a consult for our department. If they're not, the first step is to call Access and just start with services. Don't have to start with a big change.
There are sometimes people who come here who have gone to the court. If somebody's in danger and not willing to get services, that we can't force services on anybody, but there have been times where people have gotten court orders through the court here in Port Huron, and that would sort of be out of our hands. And a family member could do that for substance use services.
So I think another thing people could do generally is call and talk to somebody here for some tips on how to maybe help your loved one get into treatment. So people could do that as well. Did you have another question, Christy?
Yeah. Is it being worked on in intake to get people into programs like IDDT faster instead of getting into OPS first and then having more appointments to get into IDDT?
That's a good question. And so just like most of the programs, all the programs here, there has to be a medical necessity. And so outpatient provides all of our services. We just provide them at a much more intensive rate for people that outpatient hasn't been successful for, right? Like things may be a long time of a mental illness where the symptomology is really impacting them, where they're homeless, they're frequently arrested, they're frequently hospitalized. Those are the things that we're going to be looking at to see. So typically, if they end up and they have a case manager and a peer and a clinician for a few months that are helping them linked to community resources and they're grabbing onto those things, they don't need to come to the intensity of our program. So we do try that before they're going to come to our program.
And I believe in general, we always want the least restrictive services first.
Absolutely.
Okay. And are there programs that are specifically geared towards adolescents?
For substance use disorders, I do not believe so. I think it's more of a co-occurring in the children's department. And I don't work with children. So,
But that's a good question, and we'll make sure we put the exact answer out there. I do know that within the children's area, they do work with kids with substance use disorder. But I do think Sherry is right about it might be kids with co-occurring, but we will definitely check on that. We'll put that answer out wherever we're supposed to put the answers.
Someone
Anything
also had a
else?
question, someone also had a question about, could you talk more about what MAT is?
Medication assisted treatment, ladies?
well, medication assisted treatment is something you would talk with one of our psychiatric providers. There are also primary care providers in the community who offer that. So there are different medication assisted treatments that help with withdrawal symptoms, with cravings. And it can be short term, it can be long term, whatever you discuss with your doctor. We hear a lot more about the opioid use disorders, and people may take this long term or they may take it short term while they're just going through significant withdrawals. And they would be working with their doctor on it. There are also things that help with alcohol use disorders, and this can be, we have different things that are oral, we have an injection. And they would be meeting with the doctor regularly. With some of them, they would be meeting with our nursing staff regularly.
And if there is someone that wants that treatment, they can start by talking with their case manager, who will put in a referral and give the doctor that information that they are wanting to have this discussion at their next medication review.
And then someone asked if you could talk a little bit about the recovery court.
I think there's a training, isn't there gonna be a webinar in recovery court?
And she's doing it at the CHIP conference.
Oh,
Recovery court is something that we have started in the last few years. And a lot of the SUD clinicians, if they need a clinician at the time, we're working with them. But these are, people can be accepted to this court who have had charges related to substance use. And they have to go through a process of being accepted to the court. Right now, I think it's currently limited at around 30, but the whole team, there's a team with the judge, prosecuting attorney, probation officer, CMH staff. Once they're accepted into this, they start with more intensive services. So they would be getting counseling, they'd be offered case management, they would be working with a peer, they would have some dual recovery anonymous groups and doing different things in the community. So they would start out meeting weekly with the court staff, and then eventually they would go down. There's 3 phases of this. I think it usually lasts 2 years is what it is, but anybody can, well, most of our people come through the SUD program that get it, or they can be in the community, they can be referred and accepted, and then they will open up to our SUD program.
any more questions?
I think that's it.
Okay. Oh. I don't know what's going on here,
Okay.
so trying to get back to the last slide just says, thank you, not sure where it's at. But I just want to close it out by saying, thanks again to Jen Ritchie and Sherry Jessup, supervisors here at Community Mental Health. We hope that you enjoyed our session, and if you have any additional questions, contact any of us on anything that we said, and thank you and have a great day, and I hope that you attend a bunch more of the webinars throughout the month.
Thank you, ladies. Like I said, there are many more Recovery Summit presentations coming up. And you can see all of those at our on our website at www.sccmh.org under the events tab. Thank you again for joining us today.
Shut it down. Go touch the hang up over there. If you touch that hang up on there.